Okay, and now it's in the corner. Okay.
Good?
Yeah.
Where were we?
Yeah.
I had my hand like this, and we were doing. You
Oh,
just
we're
finished
the oblique.
exposure, but
Oblique.
I was asking about that.
That one?
Yeah.
You could, I mean, if your patient was more comfortable holding their own fingers.
Oh, okay, so I
Would
guess
that help though? Like for me right now, that would help me. But I'm saying if
Yeah.
their finger was.
Cause like me, I can't keep
Messed
my
up?
finger parallel. You get what I'm saying?
You can't.
And so
Nobody
like, how
can.
would I keep it parallel?
Well, this,
I guess if you rest it up against it,
Where is the zoom in,
it
zoom
just
out?
kind of sticks.
yeah, it sticks there.
Where is the zoom in,
Pretty
zoom
much.
out?
I just
Oh,
wasn't
zoom
sure
in.
if like
Zoom in,
maybe.
zoom out.
I guess it'd be just your
There's too
patient
much
being
zoom
more
in
difficult.
now.
No,
If
that's
they were
okay.
like kept like
Okay.
sliding it back down on
They
you.
shouldn't.
I'm just, but
You just never know.
you got people out there who love to.
Trust me.
Usually they don't. I mean, honestly,
They're trying to get
they're
out.
hurting and they want to know what's wrong. And, yeah.
Well, let's
Patients.
just hope we don't run into that.
So for the PA oblique hand, just rest your hand up against the sponge. So we've got the metacarpals in touch with, or in contact with the IR. We have that fifth digit in contact. We're gonna separate our fingers just a bit. Okay, we've got the long axis of the part aligned to the long axis of the IR. And we are centered still at the third MCP joint. We don't want that thumb up. We're not hitchhiking. We want it separated from the other fingers a little bit.
Where's the line for
Hmm?
the central ray? I'm not seeing the other line. Okay, I see it now.
I was gonna say, isn't it still at the third?
Okay, move your hand over a smidge.
Okay, there you
There, the central ray is centered to our IR. Watch this thumb. Make sure, see that light? Make sure you've got light on that thumb. Now I know it looks like a lot more light on the IR than what you have past your thumb, but you're centered correctly at the third MCP joint. Shucks. It's right at 40. If I do this, it's 41. So make sure that your tape
Straight.
measure is vertical when you're measuring for your. Hey, did you move?
You moved this.
Why does
so
something
it threw
seem
that
like
off.
it's angled? Like, I don't know.
Seemed like
It's
it's
kind of
angled.
throwing me off. Like this line that's going on is throwing me off. It doesn't, I don't know. Maybe it's just me, but it looks weird.
Well, see, if you turned it
Oh,
to
then
match
it's
the
not.
long, yeah, and
Okay. So you just feel more focused on that.
so, I mean,
Bam.
you could lift the wrist, but,
I just didn't know if like that's something to look
No.
out for.
so, yeah, we've got the metacarpals rested on the IR, centered to the third MCP.
Parallel. Well,
Excuse
not
me.
parallel. With the long axis, right?
Our patient's seated sideways to the table,
Your arm.
I have shielding.
shielding, hold still, exposure. So that's the PA oblique hand. The hand is obliqued at 45 degrees. For the fingers were obliqued at 45 degrees. So now for the lateral hand. Let's see. Okay. You can use the sponge, and for any of these projections, you can use the sponge, but you don't have to, if you find it easier not to.
Do they have these at clinicals? No. Okay.
Yes and no. If you ask for this sponge at clinical,
Probably not.
they'll probably say, there might be one around here somewhere. And some places may have them. So put your hand sideways. I have to tell you, on the lateral hand, I'm not a fan of the sponge. I think it can cause more problems than what it solves. You want to keep those fingers straight. Straight. I just don't like it.
Seems weird.
I'm trying not to be difficult, but
So your fingers have to be straight, fully extended. If they're flexed, then you close joint spaces. So they have to be straight. Each one is parallel to the IR. In other words, you don't have the distal tips lower than the proximal fingers. So each of the fingers is parallel to the IR. You have this thumb down here. You don't want it to be hitchhiking. You have the long axis of the hand parallel to the long axis of the IR, and the long axis of the hand is aligned with the forearm. And for the lateral hand, you're centering at the second MCP.
This one.
What's that?
This one. I'm not understanding the whole parallel part because
Okay.
like her middle finger, like that, like I don't get what do you mean parallel to the IR? Because it's kind of
And-
angled.
We're including the distal 1 inch of the forearm. So would you say that this finger's parallel to the floor?
Yeah.
Oh, okay. Guess I kind of get it.
So if her
It's
fingers
not angled.
Oh, okay.
Were-
I got you. I got you.
like this, then the finger isn't parallel to the IR because the proximal finger is higher than the distal finger. Now, that's parallel to the IR, which is what you want to keep joint spaces open. I think what's really hard about the lateral hand, there are a lot of details to keep in mind. You need to have the fingers separated. You need to make sure that the hand stays lateral. That's the thing that happens most often is you start with your hand lateral. Then once you separate those fingers, the tendency is to roll the hand over, to rotate the hand. So after you separate the fingers, you still have to make sure that hand is lateral. See?
so wouldn't you just want them to like adjust their wrist and their elbow to like help with?
Yeah. And this is why I don't like the sponge, because I think it leads to rotating the hand. So if I have your hand lateral, and I just want you to separate all your fingers,
That's gonna be hard to keep them parallel.
Okay. Keep your fingers straight. To me,
Oh, that doesn't
I
look
think
too
it's
bad.
easier to do that. I really do.
I do too.
So that's what at clinicals,
We're probably gonna
if we
see.
come across this, we would just be able to do it this way.
Yeah, yeah.
They did a lot of the hand one at St. Anthony's. Well, where's his at?
So your hand's lateral, your fingers are extended, they're not flexed. Your fingers are separated, and each finger is parallel, remains parallel to the IR. We're centered at the second MCP joint.
And that's only for lateral hand.
That is your lateral hand.
That's what I'm saying. That in the second.
Yes.
That's the only time you do
Yeah,
it.
for your PA hand and your oblique hand, you're centered at the third MCP. Yeah, there you go.
Okay.
I was going to say something that was profound, I just know it. Oh, okay, so hold still, exposure. Oh, you're going to see a lot of techs do this. They're going to give their patient the instructions. Give me the OK sign.
Oh, that's what I was gonna ask
That's
about.
what's on my
'cause
binder.
in-
over there.
They'll do this.
That's what I was wondering.
Folks,
how that was.
That's wrong. Don't tell your tech that. You shouldn't have the soft tissues of your thumb and index finger touching. And
It's bent.
yeah, your fingers flex. It closes joint spaces. But sometimes what techs will do is they'll say, give me the OK sign, and then they'll say, just straighten out that finger. So they're giving their patient instructions. Everybody knows what this is. Although I heard on the news last night it's a gang sign. I'm like, what? That's just wrong. So they may tell the patient, you know, because everybody knows how to do this, they may tell the patient to give them the okay sign and then just straighten out this
And
finger.
it also kind of makes the other fingers like stay straight. And do
I
what
think
you need
so.
them
I was
to
gonna
do,
say,
and
yeah,
you
that
kind of
would
just
keep-
let it
Yeah.
out.
Those ones at least, and then you
Okay,
could.
so that's the hand.
I think in the book it mentioned something about doing that though, doing the okay sign.
Does it? Well, I know
I thought it did. Maybe I'm going
it shows
crazy.
you this for
Or
the
maybe I heard it
oblique,
from somebody
which
else.
just sends me over the edge.
Oh, that.
Yeah, because I know it says, you know, if your metacarpals are of interest, then you can rest the fingers. I just, honestly, when I was a tech, anything that I was ever taught that. 45 degrees. Yeah. Okay, so that's the hand. Shall we move on to the wrist?
So excited.
Me too.
Are we doing the thumb?
Yeah, let's do the thumb next. All right, this is tricky.
I was like, she's making a face.
This is an AP thumb. So if you start with your palm touching the IR and you medially rotate the arm and hand, woo! Oh, Lordy. Overachiever. That's what you want to do. You start with the palm down, medially rotate until that thumb is placed AP.
So you just want them at like a 45 again.
No, because this is the AP. So you want that thumb in a true AP so that it's not rotated either way, but flat. This is great because she's able to get these fingers out of the way. Notice how the long axis of the thumb is aligned to the long axis of the IR and aligned with the forearm. That is what you want.
My hand would get in the way.
You're centering to the first, meaning the thumb is the first digit, metacarpal phalangeal joint. This is different than the finger. The fingers, you are centering to the proximal interphalangeal joint, but for the thumb, you're centering at the MCP joint. Collimate in, and when you collimate for the thumb, you have to make sure you include the trapezium. So you're including the metacarpal, the first metacarpal, and the trapezium, that carpal bone.
So would you say it's safe to say, like you see this right here, would you just kind of keep the light past that, or is that too much?
No, I include the trapezium.
Like, I don't
So
know.
really, I mean, that's her wrist.
I was gonna say where the bone.
Yeah, like where the bone is
Yeah.
can you use
You know,
that
I
as a
always
pinpoint?
hesitate to give landmarks like that. Yeah, just because it's not anything that we use or learn, and I want you to stay focused on including the trapezium, which is,
I was gonna say it's like
A wrist bone.
probably
yeah,
right
So
in
no,
line.
just like how do you know if you didn't clip it without having to like redo the X-ray?
include about that much.
Okay.
Well, you know what, all I can say is, you know, that's the end of your carpal,
Yeah.
and right below it is the trapezium, or I should say above it is the trapezium.
So like an inch maybe?
So this joint here, that's the carpal metacarpal joint. So about that far down is your trapezium. Oh, that's about where I sent it. Or collimated to. Okay. All right. We provided shielding. Our SID is 40 inches. Hold still. exposure. For the thumb, all of the thumb projections, no digit marker is necessary. If they don't know that's the thumb, it's pretty bad. All right, now then, just place your hand flat on the plate. Look how, by doing that, the thumb is naturally obliqued at 45 degrees. But we're not finished because we've got the whole long axis thing to worry about. So I'm going to move your hand. Sorry, ma'am. No, that's not very nice. Okay, well, that's screwy too. Okay, so again, we've got the long axis of the thumb parallel to the long axis of the IR, and the thumb and the forearm are aligned straight.
So it'll always be oblique.
What's that?
It'll always be oblique.
Yeah, unless, something's really messed up.
I've noticed, like, it's pretty much always been in line with that
Yes.
arrow at the top. So is that okay? Like, instead
Yeah.
of me being like every time, not that I can't use this, but I'm just,
If that
Well, if ideally
will
I
help.
want the point where I'm going to center, I want that to be
pretty much.
in the center of the IR.
Yeah.
So you can see I'm centered at the, if it were fractured, I wouldn't do that. Well, see right there, first MCP. Okay, center at the first MCP, and that is,
Pretty
my
much.
central ray is centered to my IR. My thumb's naturally at a 45-degree oblique. Again, I want to make sure I'm including the trapezium. I did, I'm sure of it. Got my left marker here. Hold still, exposure. Are you ready for this? Now for my next trick. Just arch your fingers.
Like, oh, like that? Oh,
Mhm.
gosh.
Is that hard? Okay.
I didn't know if you wanted me to, like, I guess curl them a little bit. That's what I was trying to do at first.
You're just bringing that, when you arch your fingers, your thumb naturally
Raises.
rotates
Yeah.
into that lateral position. And you're making sure that the thumb is in a true lateral position. And again, you really can assess that by looking at the fingernail. Do you see what I mean? So let's flatten your hand a little more. See how you can see
is curved.
more of the fingernail? You don't see it in profile. You should see that fingernail sideways.
Oh, I get what you
So that's the lateral thumb. Center to the first MCP, metacarpophalangeal joint. Hold still. Exposure. Wait a minute. I did the hand first, didn't I? Didn't I already do the thumb? No? You let me skip?
You started with the fingers.
That's why I
I
asked
went
what we're
from the
gonna do
fingers
the
to the
thumb.
hand.
Yeah, that's why I asked.
You guys let me do that. Awesome.
Well, I thought the first one you were gonna do the thumb because you had all of mine out, and then I just thought you were kind of gonna move into thumb, but then you started doing my digits, so then I was like, okay, I'll just let her do her thing.
All right. Cool. All right. Now for the wrist. I really appreciate you being the same patient. It helps us move faster. Are you all right with it?
Yeah, I'm.
Okay. No, oh, no, don't, no,
Oh,
never
okay.
record my face.
Oh. You didn't
Now-
make up any.
When her hand is flat on the IR, do you see there's a gap under here?
Yes.
Do you see that? Did you see it?
Yes.
Now then, I want you to arch your fingers. Do you see how that brings the wrist closer to the IR?
Yeah, the gap is not.
That's what you want to do. We're centering mid-carpal. You're including the distal metacarpals and the proximal radius and ulna. And again, you're centering mid-carpals. And you're going to know you're centered because you're going to see the same amount of light to the medial side as you do to the lateral. Okay, that's not an anatomic position, but you're going to see the same amount of light on either side of the wrist. Including our left marker. The long axis of the part is aligned to the long axis of the IR. Our patient's still shielded. Our SID is 40 inches. Hold still, exposure. Now for the oblique, 45-degree oblique. 45. And again, you're centering mid-carpal and you're looking for that same amount of light on either side of the wrist. If you center, and this is what you see, less light over here than over here, it's not a collimation issue, it's a centering issue. We're including the proximal metacarpals and the distal forearm. We have our wrist oblique at 45 degrees. And notice I'm not using a sponge for that. You won't use a sponge when you're positioning for the oblique wrist. You're going to eyeball it. And if you're wondering what 45 degrees looks like, you can use this when you're practicing to get an idea. That's 45 degrees. That was the oblique wrist. Watch this. Bloop. Lateral wrist, one and done. Thumb up. You want to make sure that your wrist is truly lateral, not rotated one way or the other. Long axis of the, you know the long axis stuff, right? Mm-hmm. Okay, that's good. Center to mid-carpals. I have about equal distance or equal amount of light on both sides of the wrist. My left marker included in the collimation field. Okay. Hold still. Exposure.
So for sound purposes or just purposes, period, collimation is more important doing the hand than it was like the other stuff we learned because we didn't really collimate as much.
It's
so
not that it's
required.
It's not that it's more important, but you're imaging a much smaller part, and there's no reason
To have that much
to
light
have this entire IR exposed.
So we would basically need to.
Elbow.
Oh, that's fun.
What?
I just don't know how my elbow is gonna go.
One thing I didn't mention, but very important, on the wrist, for starting at the wrist, the shoulder has to be at the same level as the rest of the upper limb. Another way to say that is that the shoulder is in the same horizontal plane as the rest of the upper limb. So if her shoulder is higher than...
I just want to see what she's talking
Well, no,
about.
Or
that's what I was
hand?
gonna ask you because I
Hold on,
kind of had
hold on.
mine.
Yeah, if her shoulder's higher
Okay,
than her
okay.
wrist, there are a couple of things you can do. Just kind of scoop forward and slouch back. There. That fixes that. And I should have addressed that when I demonstrated all of those projections. So starting at the wrist, that needs to be the case. It's the same for the forearm, same for the elbow. Now then the forearm. It's the only exam of all of these that I'm demonstrating that requires a 14 by 17 image receptor.
Interesting.
Do you need like any more than okay? Just
Put your arm out
don't know how
here.
much light.
You're supinating your hand. This is an AP forearm. I'm going to make sure that your forearm is centered to the IR. And I'm looking at the distance from the wrist to the end of the IR. Should be about the same distance as it is from the elbow to the end of the IR. And if that's the case, then all I really need to do is center to the IR. Woo.
So for forearm, we have to include all of that, not just like this.
So
but
for
all
the
of that.
for the forearm, you have to include the proximal metacarpals and the elbow joint. So you have to include the wrist joint and the elbow.
Okay.
There you go. Now, to make sure that the forearm is positioned in a true AP, you have to palpate the epicondyles. They have to be parallel to the IR. And you can feel those on yourself, or here.
I feel
Here.
this
Oh.
one.
I
can't feel
wasn't sure
yours.
what you Okay, yeah, that.
Yeah. So you're palpating to make sure the epicondyles are parallel to the IR. That tells you that the arm's not rotated. That's an indication that the arm's not rotated.
So you wouldn't necessarily want, so, because like right now, you're all the way over,
Are you
like
looking for this
with, this wouldn't, it's not gonna go any farther, is what I'm saying, the tube. So I'm saying, you wouldn't necessarily want to scoot your patient that way. I don't know,
I don't know. I'm not following.
okay, because like I was saying, I could sit back up and like scoot that way for the tube and everything. Does it
Yeah,
make
we
sense?
may have to do that, but we're all right for now.
Okay, that's what I was trying to ask. Was
Yeah.
it?
So our forearms, the long axis of our forearm is aligned to the long axis of the IR. We're centered mid forearm. We're making sure to include soft tissue to either side. We have about the same amount of light on either side of the forearm. So that indicates we're centered side to side on the forearm, including the proximal metacarpals. We're including the distal humerus. So we know we're including the elbow and wrist joint. I don't know how much else I can say. SID. It's 40. Shielding. Hold still. Exposure. Now, to this point, for the finger, thumb, hand, wrist, we've had the PA, AP for the thumb, oblique, and lateral. When it comes to the forearm, you only have 2 projections, AP and lateral, no oblique. So I want you to scoot your chair forward.
Is it because with them crossing, you really won't get much info if they were to be crossed?
Yeah, there's just
There's nothing you can really do with that.
there's just no oblique forearm.
I was gonna ask the same. Why is there not one?
No, somebody decided that's how it should be.
Okay.
So we want the shoulder in the same plane.
This looks difficult.
Now, important, for the lateral forearm, you want the elbow flexed at 90. So the upper arm and the arm should be at 90 degrees. You want that thumb up. I don't know why it didn't hit you, but seemed to work. And there again, you want about the same distance from the wrist to the end of the IR on either end. Doesn't have to be exact. So we can center mid forearm, sorry. You have to make sure you include that posterior elbow.
So you gotta have light on this side too.
Yep, absolutely. We're centered to our IR. Long axis of our forearm is parallel to the long axis of the IR. Okay, I can collimate, but notice I could collimate pretty close here, but look what I'm doing.
Cutting off that
Yeah,
part of her
you
arm.
want to include that whole joint. So I'm going to open up that collimation a little bit. Again, lateral. Some texts will say, give me a karate chop.
But then you want to make sure that their thumb is up.
It doesn't matter too much.
As long as it's
But
just
your
like, you talking
thumb,
about just on
your
the
thumb,
top.
your thumb is up. I mean, not up,
Yeah.
but
I was gonna say it's
Up
naturally
wide.
gonna just.
on, yeah. As opposed to down. Yeah, that would be very awkward. All right. Hold still. Exposure.